once your presentation is over, we will, whenever you're ready, we can bring everybody in because it's also going to be recorded, sir.
All right, fine.
Yeah, we'll be streaming it live.
We
called
everyone on
everybody
YouTube.
Yeah, now that is.
I think it was clear, no, Sammy?
Yes, absolutely. Yeah.
Shall we start, Parul?
नमस्ते दोस्तों, स्वागत है आप सबका हमारे शनिवार के आज के सेशन में। डाउन सिंड्रोम फेडरेशन ऑफ इंडिया की तरफ से मैं पारुल सिंह आप सबका स्वागत करती हूँ। दोस्तों, हम हमेशा बहुत सारे इंफॉर्मेटिव सेशंस आपके लिए लाते रहते हैं, उनमें से ही आज का सेशन बहुत खास है। एक बहुत बड़े शायर ने कभी कहा है कि दफन कर दो हमें कि सांस मिले, नब्ज कुछ देर से थमी सी। ये जो सांसों का कारोबार है ये बहुत जरूरी है। सांसें हमारी जिंदगी के लिए इतनी जरूरी हैं कि ये वही समझ सकते हैं कि अक्टूबर के मंथ में दिल्ली में बैठकर मैं जो हार्ट सर्जरी सर्वाइवर हूँ, मेरे कॉम्प्रोमाइज्ड लंग्स हैं, तो सांस लेना इस समय में मेरे लिए कितना मुश्किल और कितना ज़रूरी है, और शुद्ध हवा मुझे मिले और मेरे लंग्स भी हेल्दी रहें, और क्या क्या प्रिकॉशंस मुझे लेने चाहिए, उन सब से मुझे गुजरना पड़ता है। तो मैं बहुत अच्छे से समझ सकती हूँ कि हमारे सेल्फ एडवोकेट्स जो डाउन सिंड्रोम ब्लेस्ड है उनको किस किस तरह की प्रॉब्लम्स आती हैं, क्योंकि ब्रोंकल एरिया नैरो होता है, बहुत सारी चीज़ें ऐसी होती हैं जो उनको इस मौसम में खासकर परेशान करती हैं। तो आपकी इन्हीं सब प्रॉब्लम्स को एड्रेस करने के लिए बहुत सारे हमारे पेरेंट्स परेशान रहते हैं कि बच्चा स्लीप एप्निया से परेशान है या किसी और चीज़ से परेशान। ऐसी बहुत सारी परेशानियों का सिर्फ एक ही इलाज हो सकता है, जो एक्सपर्ट डॉक्टर हों जो आज हमारे साथ हैं। एक पल्मोनोलॉजिस्ट बहुत खास, बहुत अहम रोल रखता है हमारी सबकी लाइफ में, और वही आज हमारे खास मेहमान हैं जिनसे मेरी दोस्त समीक्षा आपको मिलवाने वाली है। समीक्षा, मैं आपका स्वागत करती हूँ। और हमारे साथ डॉक्टर रेखा रामचंद्रन भी हैं, डाउन सिंड्रोम फेडरेशन ऑफ इंडिया की प्रेसिडेंट। मैम, आपका स्वागत है। समीक्षा, मैं आपसे चाहती हूँ कि हमारे आज के गेस्ट से हमें मिलवाएं।
Thank you so much, Palu. Good evening, everyone, and welcome in today's session. Yes, Down Syndrome Federation of India's continuous efforts are for making it possible to discuss each and every medical and behavioral challenges we as parents come across in the journey of raising a child with an extra chromosome. And at this platform, and especially like Paru rightly mentioned, the winter starting in north and festivals like Diwali and all the festivities till the end of the year are going to be in the society. It makes today's session even more important and essential for us. And we are very thankful for our resource person for giving his consent for coming today. So people with Down syndrome, as we all know, that are more likely to have problems like sleep apnea and other sleep disorders, and these can impact their lung health. So the diagnosis and treatment of sleep disorder in the persons with Down syndrome are therefore essential to prevent additional consequences and comorbidities. Federation is so happy to bring Dr. Nagarjun, who is dedicated to excellence in pediatric pulmonology and sleep medicines, particularly focusing on improving the management of respiratory and sleep disorders in children. His contributions to pediatric pulmonology and sleep medicines are well known and notable as well. He has co-authored numerous papers and chapters and presented them to other experts and also the student in the same subject matter. For his efforts at various levels, he has been awarded and received numerous honors at different platforms. We are not going to list all of them because if we talk about his expertise, it's going to take a lot of time. You will get to know when you hear that the kind of expertise he holds on the subject. We are quite lucky to have someone with his level of expertise on such an important subject on the right time of the year. We are delighted to welcome you, Dr. N. Nagarjun, a pulmonologist and sleep specialist. We want to know more about respiratory and sleep related problems in person with Down syndrome we can come across. And we also want to know whether you can help us understand how to manage these problems and when it's best to consult a specialized specialist in this area. Very warm welcome over to you, Dr. N. Nagar.
Am I audible?
Yes, sir.
Good evening, everyone. Firstly, I would like to thank Down Syndrome Federation of India. Firstly, for supporting such a novel cause. The work that you do is extremely commendable. Secondly, I always felt like, especially genetic syndromes, like you mentioned, an extra chromosome, they have multiple issues that parents are not usually aware of. And just with treating with a pediatrician would not suffice. You would require something called as a multidisciplinary care, as in you would require a team of doctors to help treat all of your problems. Since my specialization is only pediatric pulmonology and sleep, that is children lung related and sleep related issues, today we will be focusing on only the lung and sleep related issues in children with Down syndrome. Since the sleep related issues I think are more of a concern, today I will be focusing only on the sleep issues, but then I would be more than happy to answer questions or do another session on the respiratory related issues. If you could share my screen, then I could start my presentation, please. Thank you so much. So, like I mentioned, today I will be talking only about sleep in children with Down syndrome. Most of us know that we spend 1/3 of our life only in sleeping. But then, why do we talk about it? Should we talk about it? Do we not talk about it? Do we consider sleep as just a phase where that you rest and then you wake up in the morning? I believe, I believe in a very strong Buddhist quote that says, every time that you sleep and every time that you wake up, you're reborn every time. And I think that holds so much value in what we treat, because we would like all of our children to have extremely good sleeping practices, fall asleep well, have a sound sleep, have good quality of sleep, and then wake up fresh. So some of the benefits of sleep in children are obviously, one, it helps in the growth and development of the child. Okay, and you need good sleep to have the right amount of growth, and you want to see that in a developing child, whether it is a neurotypical or a neuroatypical child. Next, please. So some of the other benefits of sleep are, one, when you sleep and then you wake up, your emotional regulations are so much more better. You feel so much more fresh. Your energy levels are so high. Your attention span is so much better. It obviously has an impact on your memory. If you compare to a child who does not sleep, or just in fact as an adult, if you don't sleep well and then you wake up the next day, your mood is so bad. Your attention to detail is so less. Also, in the long term, we've seen that children or adults who do not sleep well tend to be on more weight or tend to develop obesity compared to the other children. Next slide. So this slide just shows the number of hours and adequate amount of sleep that is required. An infant is no one but a newborn up to the age of 1 year should be sleeping nothing but up to 12 to 16 hours. Whereas a toddler who's a preschool child, that is between the ages of 1 to 3 years, should be sleeping between 11 to 14 hours. As an adult, I would recommend that we sleep at least for 7 to 8 hours, that is 7 hours of continuous sleep, and a preschool 10 to 13 hours. So if you notice, as our age increases, the amount of sleep that we require decreases. But we still require a minimum of 7 to 8 hours. I don't know how many of us are able to manage with 7 to 8 hours of sleep, or we're not able to get in because of our kids or because of the work. But that is what is ideally recommended for ideal body functioning. Next. So sleep disorders in children are very, very common. In fact, when I started out in this field, I realized why do we talk about sleep so much? But very soon, at the end of this talk or in the next 5 years, you realize that sleep is going to be the next big thing in every country. It is like what we call as an pandemic or an epidemic. Sleep issues are going to be an epidemic in our country. Nearly 25% of the children aged 1 to 5 years develop from or they suffer from sleep issues, but most of the parents don't have concerns about it. Also, pediatric sleep issues are very different from adult sleep issues. There are many parents who will be saying, I have the snoring, so even my child is snoring. It is absolutely common. I wake up in the middle of the night, so my child also is waking up in the middle of the night. It's absolutely common. I would probably disagree on this statement that many parents make. And obviously, sleep varies with age and developmental stage. That is probably not something that we would discuss in detail in today's discussion, because we would like to get into some more details as to what are the problems that children with Down syndrome face. Next. So these are some of the information that we've gathered all around the world with percentage of the frequency of sleep problems in children with special needs. If you look at number 3, children with Down syndrome are known to have almost 50 to 100% of the children with Down syndrome definitely have sleep issues. When you compare it with other conditions like a Rett syndrome or a Prader-Willi syndrome, which are also genetic syndromes, Down syndrome, I would say, is slightly higher in the table in causing sleep issues. So sleep issues, in brief, for understanding of you parents, I would say it can vary from a basic complaint like a snoring. Your child might be snoring, or your child might be having multiple awakenings at night. Some parents even come to my clinic saying, Sir, I have noticed my child does not breathe at night. I've noticed my child opens his mouth and breathes. I've noticed my child tossing and turning repeatedly at night. I've noticed that suddenly he wakes up in the night and then he starts crying. A child above 5 years of age having to go to the bathroom multiple times. A child waking up in the night crying multiple times out of fear, not knowing what has happened. These are all some of the nighttime symptoms of sleep. Can you change the slide, please? So these are the nighttime. But since previous slide, yeah. So like I said, when you compare the children with Down syndrome with children with non-Down syndrome or normal children, next slide, please. The percentage of issues that the children have with Down syndrome, if you see the nighttime awakening in a child with Down syndrome is almost 32%. Mouth breathing is almost 73% compared to the 33% in a normal child. Apneic episodes is nothing but when a child stops breathing at night. So common that almost 12% of children with Down syndrome have these issues. Teeth grinding, bedwetting, sleepwalking, all of these problems are much, much more common in children with Down syndrome than children not having Down syndrome. That is why today's topic we'd like to focus on sleep issues mainly because lot of parents are not aware that okay fine, this is the issue that my child is having, what do I do next? Or two, parents are not aware that the problem exists at all, and then how to address the issues or whether the issue is really there or not is how I'm going to help you understand whether it is really there. Next slide. So you all must be wondering why a child with Down syndrome has so many sleep issues and why another child does not have, why only my child has. So there are multiple reasons as to why a child with Down syndrome can have sleep issues. Most of the time it is related to the shape of the face, shape of the mouth, and the way the Down syndrome bodies are, they're born. First, what basic understanding is a craniofacial structure is your face structure is very different from a normal child. Mid-facial hypoplasia is basically the middle part of your face. When you compare a child with Down syndrome to a non-Down syndrome child, it is much, much more flatter than in children with non-Down syndrome. Your jaw is much, much more smaller. Most of you would have noticed that your children's tongues are protruding out and they have a large tongue. All of these problems when a child is sleeping and when the child is relaxing, when the tone is much, much lower, all of these can cause obstruction to the air. As you know, all of us have a tendency to breathe through the nose only. Okay. But when our nose is blocked, we tend to open our mouth and breathe. So because of the nose being blocked, because of the tongue being large, because of the jaw and the face being slightly flatter than normal children, all of these problems can just cause an obstruction to the passage of air during sleep. So My basic logic is we use our mouth mainly to talk and to eat or drink water. But when a child starts spending his or her time in breathing through the mouth, all the energy, all the interest that is the child wants to do with the mouth is going towards breathing. And then that is why many of our parents would come to us saying, my child does not eat well at all, my child refuses to eat, and my child is a very picky eater. All of these could be because your child itself has programmed his mind or her mind saying, my mouth is there for breathing and I will use it for breathing. But that is not how we usually are programmed. We are all supposed to be breathing through the nose. Despite all of these issues, children with Down syndrome are known to have a smaller upper airway. As you know, your child gets a cold or cough quicker than most of the other normal children, and when they do get it, it lasts for a longer duration. And as you know, children with Down syndrome are known to develop hypothyroidism and obesity, which can also contribute to your sleep issues. So you must be wondering what the OSA in slide means. OSA is nothing but obstructive sleep apnea. So as the word suggests, obstruction during your sleep, which is causing difficulty in breathing, is nothing called as an obstructive sleep apnea. When a child does not sleep well at night, all of these problems can facilitate the child to have an obstructive sleep apnea. Apart from these mentioned here, a lot of us kids have something called as an adenoids and the tonsils. Most of you would have heard these terms from your doctors. Because of something that is already narrow, I would say you're in a cave. When a cave is already small and at the end of the cave you have a tonsil and an adenoid sitting, there is the amount of space that is left for air to go is drastically reduced. So I would say most of the children, after a point of age, whether we really have to start assessing for the tonsil issues, whether we really start assessing for the adenoids issue and the sleep issue, is the crux of today's topic. Next. So we conducted a survey. I'm sure some of you have answered the survey that we sent out to you. So it is basically a questionnaire that we sent out. Around 35 patients, parents have answered, and only 11% of the parents have reported that the child has had sleep problems. And only 4 parents were correct about a sleep abnormality, and the other 7 children believed to have a sleep problem at normal sleep study. But what was very, very, very surprising to me was of the 24 parents who had reported no sleep problems, we have seen that 13 children had abnormal sleep studies. And for the survey that I sent out to the parents that I just was about to go through, sleep study was something that has not been discussed at all, or most of you don't seem to know about what a sleep study is at all. And which is very surprising to me because if you see the American guidelines for management of children with Down syndrome, which I will show you in the future slides, it is mandatory that irrespective of whether the child is having symptoms or no symptoms, at the age of 4 years or lesser, a child with Down syndrome should undergo something called as a sleep study. Okay, so please understand that as parents, we might be thinking, no, my child is absolutely fine, he does not have any symptoms at all. But as parents, we are not able to recognize that this is the problem that is happening to my child during sleep. We might feel he's sleeping well, he's absolutely fine. But when you test it, the results are actually very, very different. So this is what we call as a dissociation. What you feel and to what the test shows is obviously there is stark remarkability, and that is why we force people and then we in fact screen people at all our visits that we should do a sleep study at the age of 4 years. Next slide, please. So I have already discussed all of this. What are the night symptoms of OSA in children? One, loud snoring, sleeping in unusual positions, mouth breathing, trouble falling asleep and staying asleep, periods of not breathing, which I called as apnea. And in fact, some children with Down syndrome who have obstructive sleep apnea may not have any symptoms at all. But in some children, the only problems are the daytime symptoms. One is difficulty in paying attention or learning difficulties. So if some of our parents with Down syndrome, they come to us saying, doctor, my child is extremely hyper during the daytime, I am not able to control him at all. They have been evaluated by other doctors and they've labeled them as having ADHD and having behavioral problems. But retrospectively, when we have evaluated the children, we have noticed that because of the sleep issues, we might think, see, as adults, when we don't sleep well, we become very dull. But in the children, it is the opposite. When they don't sleep well, they become extremely, extremely hyper. And it is very, very difficult to control them. Or we might feel like, no, their attention spans are very less. Also, some children come to our clinic saying just that their academic performances has been dropping over the last few years. That is also could be contributed by some of the sleep issues. There have been children who fall asleep during class. Teachers have complained to us saying, your daughter is falling asleep in the class. Please do something about it. Or you cannot bring the child to school. So these are all small, subtle markers that your child could be suffering from a sleep issue. Next slide. So these are the daytime symptoms that parent as such should be looking at. One, difficulty in morning waking, complaints of daytime sleepiness, hyperactivity, aggressiveness, attention problems, attention span, learning problems, school failure, and ADHD. These are some of the symptoms that as parents you will have to look for, because I feel the parent is the first doctor, the teacher is the second doctor, and we, when they come to our clinic, we are the third doctors. So I'm sure all of your parents can do a great job by screening out all of these problems, and then you can approach us to help you treat further. Next. So how do you want to know that my child has an obstructive sleep apnea? Only gold standard test is to do something called as an overnight sleep study. Since most of our children sleep at night, since all of us sleep at night, you will have to do a sleep study overnight in a hospital. And what they basically do is, I will show you in the pictures next. They will connect a nasal cannula, they'll connect a finger probe to check your oxygen levels. They will check the amount of oxygen going in into your mouth or not. They will see how many times you're snoring. It will sense how many times you're waking up in the middle of the night. Based on all of these data, we get a score or we get values. Based on the values, we will be able to tell, like, okay, fine, your child is having sleep apnea, your child is having mild sleep apnea, moderate sleep apnea, or severe sleep apnea. Based on the severity, our treatment entirely changes. So every child with obstructive sleep apnea is not the same. Every child with Down syndrome does not have the same issues as the other child with Down syndrome. So it is not like, oh, my child has this problem, or even your child will have the same problem. It does not work like that. But one screening test that all children have to undergo is something called as a sleep study. And again, like I said, in the survey, many of the parents were not aware that a sleep study has to be performed. I will show you in the future slides. Next. So these are some of the images. So we at our center, we do it in a very child-friendly way. If you can see some of these children, they enjoy this because we sensitize them. I know some of the children with Down syndrome have sensory issues and they don't like stickers and tapes. But then we have a very child-friendly approach that we start helping them out. We think we make them look at it as a game. We start calling them warriors. We call them as heroes. And then we eventually get them to do the sleep study because that is what is our eventual goal for our management. Next. So if you see this chart, I'm not sure how many of you have had a look at this before or how many of you have shown this before. This is what is called as an anticipatory guidelines of children with Down syndrome. These are problems that the child with Down syndrome can have. And even if they don't have, at particular ages, it has to be screened. If you see the red box, so right above the red box, if you can read, it says sleep study by the age of 4 years. So sleep study, irrespective of whether your child is having sleep symptoms or no sleep symptoms, it is mandatory that you get it done. What is the cause of obstruction is a secondary thing. Based on the sleep study, your sleep specialist will identify what is the problem, and he or she will give you the line of treatment. Next. So how is my child treated for obstructive sleep apnea? Say now I do a sleep study and then I tell you, like, okay, your child is having obstructive sleep apnea. Like I said, we will divide them into mild, moderate, and severe. If it is mild, and then we say, no, okay, fine, your child is not having so much of a sleep issue, then we will treat based on what your child current symptoms are. Whether to treat with just nasal sprays, whether to treat for the allergies if your child is having any underlying allergies, whether to treat for weight loss and that will improve your OSA symptoms, or to treat even for gastritis that could cause OSA. Also, something that we will consider, but that is again an individual basis. Each child is very different. That is what I would like to say, that my child with Down syndrome might have a large tongue that is causing the OSA. But for another child, it could be just the adenoids and tonsils that is causing. In a third child, it could be both together, a large tongue with an adenoids and tonsils that is obstructing the air passage and causing the obstruction. So in case it is a severe case, when we get a score saying no, it is a severe, next slide please, then we would ideally advise to do something called as a adenotonsillectomy. But before all of this, these next two slides are very, very important for any parent, whether the child is having a syndrome or no syndrome. These are some things that you will have to follow. It will help your child fall asleep better. One, you keep regular bedtimes. It should be the same on the weekdays and the weekends. Make sure that the child knows that they should not disturb other members of the family until after an acceptable time. Do not give food or bottles during the night to get a child to go back to sleep, which again is a very bad habit that most of us Indian parents have. Do not put the child to bed while they are still hungry, and do not put the child to bed when they are asleep. You will know that they are falling asleep and are asleep. That is when you should put the child to bed. Do not allow any caffeinated drinks, no Coca Cola, no caffeine rich foods, no chocolate, at least for 1 hour before bedtime. If the child requires an afternoon nap, then you schedule it early. Make sure the naps are done at least 4 hours before 4 p.m. in the evening. And then you avoid stimulating activities in the hour before bedtime. Some parents feel like, okay, I will get my child to be very tired, so he'll fall asleep very soon. But it does not work like that. The more the tired a child is, the more difficult it is to fall asleep. And the more you tire the child, it is very, very difficult to make the child fall asleep. You will require slow, soothing, low frequency activities to put the child. I would tell all my patients saying, have 3 to 4 bedtime activities. Say, 1, you brush your teeth. 2, you read a storybook. 3, put on your night clothes. Or if you like, say, Down children really like listening to music. Listen to some light music and then fall asleep. Make sure that these 3 to 5 activities of regular sleep, bedtime routine are followed, and it should be consistent. Next. So make sure that the child's room is quiet, create an atmosphere that is relaxing. Then the attempt should not be made to create an association between bedtime. Some parents prefer taking the child out for drives. Some parents prefer driving around, putting the child in the jula, rocking. All of these are not really avoided. But in case your child has already got used to this and saying no, he does not sleep without all of this, that is where, I mean, ideally someone like us would really help you get rid of these associations. Then you do not prolong the bedtime routine. You reward good time behavior. If they fall asleep, they perform good time routine for 3 to 5 days in a row, you reward them, saying very good. You give them a star, or you give them something that they like, or you give them something that you promised you'd give them. But do not reinforce settling and making problems by giving into demand for drinks, food, stories, and attempts to avoid confrontation. Okay, next slide. So if your child is having a severe OSA, ideally if your child is having symptoms of adenoids or tonsils, then I would ideally prefer to do an adenotonsillectomy. Again, we will have to identify who requires a surgery and who does not. Not everyone requires a surgery, but there is a high chance that even after the surgery, symptoms of snoring and difficulty in sleeping can coexist. And that is where, as a specialist, we will screen as to who will definitely improve, who will not improve. In case they don't improve, we always have a plan B. Like, this is the problem we faced. We tried treating the problem. The problem is not subsided. Now what do I do? Or next slide. Some parents are like, no doctor, I don't want my child to do any surgery. Then we put on something called as a CPAP. This is just very child-friendly machine which puts
వెళ్ళిపోయారు కదా సియా
and even in the smallest of towns, we have doctors who are trained, and we will obviously help you network to them, reach out to them, build a network, and help your child improve their sleep quality. If your child did not have a sleep study, then I would recommend that you get it done at the soonest. These are some other symptoms of children who are having Down syndrome are insomnia. Insomnia is nothing but difficulty in falling asleep or maintaining sleep. Narcolepsy is excessive daytime sleepiness. Restless leg syndrome is very jittery movements, very anxious child, always on the go, always kicking their legs around, thrashing its legs, are some of the other sleep problems that children with Down syndrome have. To conclude, if your child sleeps well, you sleep well, and if both of you sleep well, a happy parent and a family. When the parents and the family are happy, then even we are happy. Thank you so much. I hope this session was informative to you people, and I'm very happy to take further questions if there are any.
Yeah.
बहुत
Thank
शुक्रिया।
you. Yes.
Sami and Parul, if there are any, is an understatement.
बिल्कुल।
Yes,
Yes.
Doctor, I have one question which I think you hit it by saying that you have a team and that you have people in every state who
Yes.
can support us. Now this is my concern. You say that every child after 4 years has to have a sleep test.
Yes.
Now, how do we do this? Because we don't know where to go, who to contact. No one has told us how important this is. And if you say it's important, we agree. DSFI will hold hands with you.
Yeah.
We will bring our parents forward and have everyone take that sleep test. If you can sort of, get the right people to do the test. Because for us, we need people who are also, quite friendly and who will understand our parents and children. So this is your subject, and this is my thing as a president. I want to, that's why we were so keen that we have you on board, and we want you to hold hands with us and help us in this very, very big. My daughter suffered for 38 years.
Okay.
And she would sit and sleep. She was not functioning the way she should have, till we had to, though we did sleep tests here, it didn't seem to come out as she needed the CPAP machine.
Okay.
We took her to the UK, and the pulmonologist, the first thing the test showed was she needed a machine. And today, like you said, she travels with it. She can't sleep even in the afternoon without it. And she is alert and raring to go. But honestly, your presentation, girls, put your hands together. Was
Yes,
the best one.
absolutely.
Clear as crystal. I mean, I couldn't get it better. You were so good.
So good.
And I'm
So
so
good.
proud of you that the younger
Yeah.
generation is getting there. Thank you
Yeah.
so much.
Yeah.
So much for the kind
Yes.
words. So
Thank
to answer some of your questions, you asked how do we network and then how do we join hands.
yes.
So at Shishuka, we have already trained a team of close to 100 and 120 doctors all throughout India, and then we have a very good network. Most of them are trained in performing sleep studies, because pediatric sleep studies is something that is very challenging and very complex. We will have to identify. So if whoever your parents are keen on getting the sleep study done, and then if you can tell me where they are located, I will find out personally what is the closest pediatric sleep specialist that they can meet. And then I will get in touch with them saying, okay, child of so and so will be coming to you for a sleep study. Will you be able to manage?
Yeah.
So that we can do. If second of all, if parent might be in denial, like how do I know if my child has a sleep issue or not? So then we have a specific sleep questionnaires that we take history from parents. That does not require them to come to meet the doctor in person. It is not like I have to check the child. If it's more of a parent related,
Input. Yeah.
yes, and then I will do an online consultation. I will take the details. Based on that, I will tell them, okay, fine, you will have to do this next. And then after this, then you can get back to me and you show me the reports. I will tell you whom to meet next. So see, in an era where we are networking for literally everything, to find a doctor closest to you who does this should not be a problem. But our intention is to find a doctor who does it right and who does it the way we want them to do it.
Yeah.
Okay.
That's exactly what I'm saying, doctor.
Yes.
It's not about finding, it's
Correct.
about being
Connecting.
convinced that he is
Yeah.
going to make us feel comfortable. That's the most important thing.
Yes, I think it's a synergy. Parents also has to understand, like, okay, my child has a problem and he requires a treatment, and the doctor also needs to be equally coming forward saying, see, you might not be having this problem, but then I will help you show that this problem is there, and I'm there to assist you. Okay.
Perfect.
Yeah,
Yeah, girls,
it
go
is
ahead.
going, yes,
All the
Ma, it is
questions.
going in such a nice direction. And having a doctor with this kind of attitude, it really enlightens all of us and brightens our day that, yes, sleep is the golden chain that ties body and health together. So we have the right person to nurture that. Parul, you raised hand. So we will be asking you to unmute and ask your question. Please do not interrupt in between. Please raise your hand. Parul, please go ahead.
बिल्कुल, मैं अपने सवाल से शुरू करना चाहती हूँ। नागार्जुन मेरी 18 इयर्स की है, चांदनी, और वो रात को सोते में बैठ जाती है। हमेशा से उसका यही रहा है कि वो सोते में बैठ जाती है, थोड़ी देर के लिए रेस्टलेस रहेगी, और कई बार कंप्लीटली बेंड हो जाती है, सर को अपने पैरों पे रख लेती है और उसके बाद फिर से लेटती है। हम लोग, ये चांदनी है, और हम लोग 2 पिलोज उसके लिए यूज करते हैं।
Okay.
उसके लिए ऐसा होता है, जब वो उठ के बैठती है तो मैं उठ के बैठती हूँ, उसको थोड़ा पानी दिया किया, उसको खांसी आ जाती है कई बार उस दौरान। दिन में भी वो स्लीप रहती है स्कूल में, क्योंकि बार बार उसको वहां पे नींद आती है, तो उसके लिए हमने थायराइड टेस्ट कराया था, जिसके लिए उसको फिर 88 mg पर लेके गए और अब थायराइड ठीक है। और दिन में जो उसका सोना है वो बंद है, लेकिन रात वाली प्रॉब्लम्स वही हैं। अभी उसका जिम भी हमने स्टार्ट किया है, वॉक किया है, लेकिन उसका भी कोई इतना बड़ा फायदा नहीं हो रहा है। वो रात वाली जो प्रॉब्लम है वो हमेशा के लिए अभी भी है। कभी कभी कम होती है, जैसे ये दिन है इनमें ज्यादा हो जाती है, और अब जो सर्दियों का मौसम आएगा या कभी भी इसे कोल्ड एंड कफ ज्यादा होता है। एंड जब कोल्ड एंड कफ होता है वो ठीक होने के 15 दिन तक उसको कम सुनाई देता है, बहुत जोर से उसके साथ बात करनी पड़ती है। तो इसके लिए मुझे क्या करना होगा? क्योंकि रेखा माँ ने जो कहा है कि अगर कहीं दिखाने में वही डर लगता है कि सही स्टडी।
गाइडेंस मिलेगा।
Okay. See, from the, is it okay if I converse in English?
Yes, sir. Yes.
Okay. See, from the problem that you mentioned, it is very evident that your child is definitely having an issue with her sleep. Okay. I am very glad that you have worked on the thyroid, and I'm glad that you're working on her diet and you're working out to reduce her weight. Only by doing that, it is not really going to help. First, we need to understand that waking up in the middle of the night is not common. No one should be waking up. If you realize, all of us do wake up, but we just tend to fall asleep without remembering it. But when a child wakes up, changes position, sits up straight, and then even arches, it is because she's finding a position that will probably relieve that obstruction so that she can breathe better. It is her way of compensating for that block in her sleep. And ideally, we'll see if she's a 14-year-old, if you mentioned.
18.
18.
18-year-old, I would really not be sure whether the adenoids and the tonsils are contributing to her problem, because at this age it is unusual. But it is known that children with Down syndrome, because of the tone, because of all the points that I just mentioned, she will probably be an ideal candidate to undergo a sleep study. First, I would recommend do the sleep study. Based on the sleep study, we will get a score. After the score, I can guide you as to how you can go for. Because 14, 15 years of her life, she's already slept like this, and it has really affected her life. At least going forward, at least for the next 2 decades or 3 decades, you want her quality of life to improve.
जी बिल्कुल।
And that is where we will come in. Okay. Sleep
Yeah.
study, I know, looks complex to you guys, and it is, but it is very, very simple to do it. Okay. I know there are a lot of cost factors associated with it, and there are insurance companies that don't claim it, and then there are a lot of centers that don't do it. But then, since sleep is something that is very new, we will have to start doing it first. And if someone like Parul Singh does it for her daughter, and then everyone from Down Syndrome Federation of India will be like, Parul Singh did it, why don't I do it? Right?
केयर के उसका सर्जरी होगा या उसको मशीन लगेगा, मैं चाहती हूँ वो एक ऐसी रात को
Yeah.
सोए, रात को सोए और सुबह जाके उठे, ऐसी स्लीप वो भी फील करे, मैं ये चाहती हूँ।
So we usually try to avoid any medications that put the child to sleep. We do not want to induce sleep in the child. We want child to fall asleep naturally, because everyone has a tendency to fall asleep. You might go complain saying uthti hai night pe, cheekti hai, but then someone would prescribe you medicines and be like, ah, okay, fine, your child is sleeping well. But I would really not recommend. If you noticed, anywhere in my talk, I have not spoken about medicines. Because
Absolutely.
most of the times it is not medicine that is the cure. It is because of the obstruction, right? Treating with medications is not going to clear all your obstructions.
Yeah.
Where do you stay, Miss Parul? Which
मैं नोएडा, दिल्ली में रहती हूँ सर, नोएडा।
I can easily find you a sleep specialist who will do the sleep study for you. I will get in touch with them, and then we can get the sleep study done and follow up.
जी
Yeah.
बिल्कुल, follow up
Yeah,
कर-
with yes, with DSFI, I think we can figure out on the dates
Yes.
and how many parents are interested and how we can do it in the specific areas.
Yes.
Neha, you have raised hand. Please unmute and ask your question.
Yeah, hello ma'am, hello sir, hello everyone.
Yeah.
Actually, I have a query. Like, my baby is 14 month old, and he's sleeping. Like, whenever he is trying to sleep, I'm singing glory, and he got sleep within 15-20 minutes if he has a स्लीपिंग थिंग्स। बट जब भी इसको मैं नाइट में ट्राई करती हूँ सुलाने का, तो वो 12:30-1 बजा देता है सोते, उससे पहले नहीं सोता है। उसको फोड़ दो या ना दो, डजेंट मैटर, उसका रूटीन ही सेट हो गया 1 AM पे। एंड वन मोर थिंग आई एम ऑब्जर्विंग कि एट द टाइम ऑफ स्लीपिंग इसकी आईज क्लोज रहती हैं, बट ये पूरे ओवरऑल बेड पे राउंडेड होता है। अगर मैं इसको एक कॉर्नर पे सुलाती हूँ तो मुझे वो 2-3-4 घंटे के बाद वो मुझे एकदम पैर के पास मिलता है।
Okay.
और ये ऑलवेज प्रीफर करता है स्टमक के साइड होके सोने का। तो क्वेरी है, इज दिस नॉर्मल या फिर इश्यूज हैं, ऐसा कुछ है,
Okay.
स्लीपिंग इशू है इसे?
So the position in which your child sleep is his or her preference. If you feel like the child is, see, some of us prefer to sleep on the stomach, some of us prefer to sleep on the side. The side is not a problem, but the fact that your child is turning around, it's like a clockwise. You start at the head, and then by the morning, the child is near your feet. That means the child is waking up multiple times and then altering its positions repeatedly to feel like, okay, fine, maybe I'll get better sleep in this position. Fact that your child at 1 p.m., 1 a.m. is also not falling asleep is a matter of concern. 15-month-old child should ideally be asleep by 7:30, 8:30. I know in Indian scenarios it is very difficult, but at least by 9:30, 10, your child should fall asleep. So whether you're singing a lullaby and your child is not falling asleep, or whether you're feeding the child and your child is not falling asleep, it is it is limitations that we are setting as parents to not put our child to fall asleep. So if this issue has been there for quite some time, I would like a few more details where probably we can connect in person, and then I will really be able to help you out.
Yeah.
Okay.
Yeah. I think Brinda can support in connecting to the parents. So I think after the session, parents can send their interest in the subject to Brinda. I hope that will be easy way to manage for DSFI.
Yeah, most of the sleep concerns can be managed in face to face, just like how we are meeting.
Consultation. Yeah.
Once we feel like no, you have to meet a doctor, then I will obviously recommend you like go and meet.
Yeah.
एंड
Yeah.
व्हेनेवर ही इज गोइंग टू स्लीप, वो बहुत ज्यादा फाइट करता है, मतलब पूरी बॉडी को स्ट्रेच करेगा
This is
बैक से।
this is sleep resistance. Okay, a child is resisting to go to sleep because of several reasons, and it is not because the child is having a problem to go to sleep. It is because the child is programmed in such a way that these are the things that have to go through to me. Only then I'm going to fall asleep. We have to
Yeah.
train the child to fall asleep.
Okay.
Neha, we would like to move to another speaker because we are short of time. A lot of hands raised. Deepa, you can unmute yourself and ask your question, please. Deepa, can you hear me?
Hello. Yeah, I can.
Yeah.
Hello. Yeah, sorry.
Yeah, go ahead. Yes.
So yeah, see, my daughter is 6.5. She's already had her adenoids and tonsils removed because she had severe sleep apnea. We did a sleep study, but even now, currently, she's tossing and turning a lot because she's having a severe cold and ear infection. She's already had gromets twice because of middle ear fluid. So again, middle ear fluid has developed. So I was thinking I'll have to wait before I do a sleep study again. But do you recommend doing a sleep study to assess whether she's still having the issue? Because after we did remove the adenoids tonsils, we didn't repeat the sleep study.
What age is the sleep study done first, and then what after a sleep study? When did you get the surgery done?
It's been a year and a half.
Okay, and see, the thing is, despite removing the adenoids and tonsils, right? The adenoids and tonsils are structured in such a way that there is a very high chance that it can recur. So it is very important that we see what is the method of the surgery that is done, because we know that what is the percentage of this child. Okay, fine. This is the chance that it can recur. Middle ear infection is extremely common in a child who's having adenoids issues. So my first suspicion in this child is whether the adenoids have regrown again, and that is why what is causing the sleep issues, the tossing and turning, and the middle ear fluid. Instead of doing the sleep study in your child repeated again, I would probably evaluate the nose of the child and the adenoids of the child. I would put a camera and then look at all the interiors to see whether the adenoids is causing the problem or not. If it's adenoids not causing the problem, but it is still something else, then I will have a better view when I put my camera in there and see like no parent that it's not the adenoids, it's something else that is contributing. This is what we do further.
Okay. So basically, my takeaway is we don't have to rush in for another sleep study right away.
Ideally,
We should.
ideally, very good thing that you've done is you got a sleep study. I mean, I'm very surprised that in this parent cohort that you have got a sleep study. So, I mean, it's a very good thing that you've done. I wouldn't recommend. You would ideally have to do a sleep study at point to see if to compare your first sleep study to your second sleep study. But then, I considering that availability, first you would do the nasal endoscopy to see if it's adenoids have recurred, and then if it's adenoids have recurred, then you go ahead and then do a repeat sleep study.
Okay. And also, she has, so one of the pediatricians who saw her said she has ADHD.
Okay.
She, though she didn't do a proper assessment, just seeing her for 10-15 minutes, she said that. But my daughter had been out the whole day. She had a very, this one. But having said that, I do accept that she's a very high, high energy child. And the teachers have started saying it's very difficult to hold her attention in class. She's always running out. So she's a little bit of a problem child in that sense, and they've asked for a learning support assistant because of this. So I'm wanting to get an ADHD study also done to check whether she really does have ADHD, and then if that correlates.
Okay. So really, like you rightly said, a development pediatrician is someone who should be assessing your child's ADHD. Because if you ask me to evaluate ADHD, I would say no, I can't do this because I'm not expertise. You get your ADHD screening done by a developmental pediatrician. Let them assess. Anyway, you're treating your sleep issues. If you feel like the ADHD has slightly been improved after your sleep issues, I would not say all your ADHD problems are only because of sleep, because it is known in children with the Down syndrome they can have an underlying ADHD as well, and that will require another behavioral therapy that we can discuss in the future if you're interested. Okay.
So, Deepa, we would like to move on to the next question, please. Kritika?
Sure.
Yeah, thank you, Deepa. Kritika, you can unmute yourself and ask. I'm not taking your question from the chat now. Yeah.
Yeah. Hi, doctor. It was a very, very informative session, pretty much covering our journey. Wherein my daughter Ria is 8 years old now, and we have done a sleep study for her twice. One at the age of like 4, which was just before COVID, and the reports were out, but we were not able to do much about it. And then very recently, like 6 months ago, we did one more sleep study. The doctor at MOF suggested for the adenoids and tonsils were not so pronounced as they expected. So they just suggested a puff kind of a medicine for 3 months. We are on it right now, and I see a connection between her open mouth sleeping, the tossing, and the insufficient quality of sleep that is affecting her next day. So having done sleep study twice and not got a conclusive remark is something my situation as a parent. There are many things connected here, but can you help me how to go about with my daughter's case as of now?
So, Ms. Kritika, first thing you'll have to understand that doing a sleep study is not going to treat or solve your concerns. Doing a sleep study is only going to tell you what is the level of problem, what is the severity of problem, and then we go ahead. If your doctor has already mentioned that the adenoids and tonsils have not very significantly enlarged.
Yeah, not to the level that it should be reduced in size. They gave a puff for us to try,
Okay.
maybe because of our age or something, and we are on the puff right now. They also had suggested us to the orthodontic for the upper palate expansion. We have done all the scans and X-rays done, and those are waiting.
So that's a very good point that you made. So most of the time I would also prefer to, if it is based on your sleep study findings, I would also prefer to give you a spray and to see if there is an improvement. If in a span of 6 weeks I don't see a significant improvement, then I would probably consider, okay, is there something else? Second question is, I want to know how your pediatrician has commented on the adenoids and the tonsil size, whether by just looking at it or whether he had a deeper look at it. Three, like you
Yeah, it
mentioned,
was not. Mhm. Yeah,
three
it
as
was not the. Sorry. Yeah, go ahead.
no, you can finish it, please.
Yeah, it was not the pediatrician. It was the ENT persons, the Madras ENT Research Foundation. That's where we approached for our concerns. And they did have a physical examination and then only suggested for puff, I guess. Yeah.
Just doing a medical examination would not suffice in most of the children. I saw a question which says, aren't nasal sprays medical? I wouldn't prescribe medical sprays, nasal sprays to everyone. I would take a detailed history if I feel it is some allergic component contributing. Sometimes we feel like the adenoid size can shrink. We are trying because we don't want to do surgery, we don't want to do other things.
Yeah, the doctor did mention this as a reason. Like instead of directly getting into a surgery for her pronouncement in adenoids, he said we will first try the puff for a period of 3 months and then come back to us. We are about to finish the 3 months. Yeah.
But if you've not seen a significant improvement in the 3 months, and if the adenoids and tonsils are not very big, I would ideally recommend there is no point of continuing the sprays or doing the surgery. Your child would be an ideal candidate to start him on or her on CPAP. Orthodontic treatment, please understand, it is not going to solve your problem. It is an adjuvant. You do CPAP, you do surgery, orthodontic will go side by side and it only be a parallel aspect. Some parents will come to me like, no, I'm doing orthodontics, I don't need your treatment. I would probably disagree with them saying it is not going to solve all of your problems. It might solve your palate issues, might definitely help your mouth breathing that your child has. But again, please understand it is an adjuvant treatment and it is not the only treatment. And
Okay.
if you go to your orthodontist, please have a discussion with him about myofunctional therapy. Myofunctional therapy is something where you can exercise your pharyngeal muscles, your tongue muscles, your lip muscles to help. Like say, I've been breathing through my mouth since 8 years. Suddenly you ask me to breathe through my nose, I will not be able to. I train myself repeatedly to breathe through the nose and keep my mouth shut. It is called as myofunctional therapy. There's an entire aspect to it, and that is how we do it. But then it is very complex. If you are in Chennai, there are some of the very few very good myofunctional therapists that we can recommend, pediatric myofunctional therapists that you can meet.
Sure. Yes, I'll get in touch with DFCFI for the contacts. And
Right.
also, the last part of the conversation really did give me a clarity on that both are different. It's just a parallel treatment. It's not one after another.
So
So that
because
was very useful.
if you go to an orthodontist, they will sell their treatment saying this is the best. But then when you go to an ENT doctor, they're saying no, adenoid and tonsils are the best. You come to me, I will say you do all of them, you don't do all of them, because since we deal with those issues, we will be able to give you a better idea. It's called a holistic approach. So we would like a holistic approach to every child with Down syndrome. Not only respiratory issues, every issue that the child has with Down syndrome requires a team approach and a holistic approach.
Yeah. Thank you.
Kritika,
Thank you,
I
doctor.
think we would like to move ahead. Thank you, Kritika. Doctor, again, the parents want to know there are good sleep study centers in Chennai also, and there are other experts also, our therapists from the DSFI panel, they also joined. They are also finding your session very, very informative for as an expert to supporting a child with Down syndrome. So they are also getting benefited with the information you have shared. Thank you so much for doing that. We have Bindu Cole and we have 3 hand raised. I'm sorry, after that we won't be able to take questions. We have already overshot time. Bindu, you want to unmute yourself and ask? If she's not able to unmute herself, Ratna, I would request you can unmute and ask. And I'm still
Hello,
admitting.
hello.
Yeah, Bindu, we can hear you. Yes.
Thank you very much, ma'am. Thank you. Actually, thank you very much, sir, for giving us such a knowledgeable session. Actually, we parents are not aware of this kind of technologies and all this thing. Yes, just like Rekha ma'am told us that early, if we have known about this sleep therapy or something like that, we have done with our children. Really, because for me, it is new one. So I got the answer from Parul ma'am's question. The same happens with my daughter also. And I would really, from my side, I would really please conduct a session in Delhi NCR region. So it will be very helpful for us. Thank you very much, sir. Thank you very much. God bless you.
So that was the third parent in a row from Delhi NCR. So I think we need a kind of information here. Yeah, doctor, over to you.
We will definitely help you find someone. In metropolitan cities, it is not a difficulty at all finding
Yeah.
doctors. I saw some questions from Hyderabad, Chennai,
Yes.
Mumbai, Pune.
Yeah.
That I can mention names now, but then we will do it in a structured format. And
Yes, sir.
Sindhu, you don't have to feel bad that you don't know about sleep issues, because to be honest, 5 years ago, even neither did I. And it's something that is very new to India. So slowly, now that we are here, we will definitely start helping you out, and then we will network better.
Thank you very much.
Yeah. Ratna, you can unmute and ask.
Thank
Ma,
you.
you want to ask something?
Hello. Yeah, hi, good evening,
Yeah.
and thank
Yeah,
you for this
Samit.
wonderful session.
Yeah.
We've received a lot of clarity. See, one is that most of the symptoms that you have said is there with my son Rushan, who is about 6 years old now. And I'm not sure whether Kolkata is in your radar, but I would definitely like to get some inputs where we can do this sleep study. Uh, because couple of things, and one more thing I want to just highlight is he has had adenovirus about 2.5 months back, and since then a pattern that we are seeing is he's sitting, taking a pillow and rocking on it while he's sleeping. I mean, presumably sleeping, but he's continuously rocking for some time, then lying down wherever he is, and then if we put him to bed, we take him up, we gently put him to bed, he goes off to sleep again. Maybe after again hour or 45 minutes, he'll snatch that pillow and start rocking on it again.
Okay. See, we will definitely find a Rishabh, a good center in Kolkata that can help you deal with your sleep issues first. Second, you need to understand that any infection, whether it is an adenoviral infection or not, in a child with Down syndrome who has sensory issues, it is going to be a setback.
Sure.
And for them to have probably a self-stimulatory behavior, they could probably be doing this is one, because I need some more details. Two, it is very common that a child who's having these regressions or these sensory issues can develop these rhythmic movement disorders or rhythmic movement activities like this rocking or having a pillow. All of that we will require to do a more detailed evaluation. But I don't think if it is something that has just been there for the last 2 months, for something for you to be really worried about. If it's an issue that has been there for no more than 3 months and it is causing distress to him, then we will really intervene and say like, okay, no, Rishabh needs this and this treatment.
I
Samit,
have a question here, doctor. Sorry, I know I'm overstepping on time, but is it okay to rock your children to sleep?
No. Only thing that you would recommend any parent to do for a child to fall asleep is one, you hold the child or you pat the child. We've noticed that children, we've actually done studies saying that you remember these construction workers, they put the jula to the trees, they rock the children. Children who are sleeping the jula or have been rocked, right? Their brain activities are much more different and very different the sleep stages that they have from the children that do not have the rocking, because you need a few stages of sleep that to set in to have restorative sleep. And when you do the jula or when you do the rocking, right, you don't go into deep sleep, and you want deep sleep for proper restorative functions. I wouldn't recommend it. So only thing that you would remember, pat or hold. I've seen some parents walk the child. There are some of these self-proclaimed sleep experts who claim to know a lot about sleep. They'll be like, 2 days ago there was a parent who came to me and they were like, 2 hours mother should hold the child, 2 hours grandmother should hold the child, and literally in the middle of the night the parents are holding the child and falling asleep.
Yeah.
So basic thing is, don't do something that you don't want to keep doing for over the long run. Simple.
Yes.
Yes.
So just taking cue from what Rekama asked. See, the way we put Rushan to sleep or to bed is that we put him on the lap, give him a pillow, and we pat him, we rock him on the lap itself. So is this a good pattern, or can it be one of the reason why he at the middle of the night searches for a pillow and starts rocking on it, uh, just to find that pattern, just to go to sleep. I mean, it's just a question, but obviously I would like to connect with you offline and have a discussion around this.
Yeah. So in a child, if it is a absolutely normal child, 6-year-old doing these activities, I wouldn't recommend. But in a child with Down syndrome, because of the sensory issues, we probably consider, okay, fine, they have these associations of falling to sleep. We would call them associations. Wanting the pillow to sleep would be an association. Always remember, when putting your child to sleep, you need to sleep. You get rid of the child when he is drowsy. Very small stage where he's drowsy and he's fallen asleep. You need to identify that stage where he's drowsy and then you move him off your lap, put him on the bed. This pillow thing, what I would be an association which would be slightly difficult for a 6-year-old to get rid of, but I'm not saying it is impossible, but we can train.
So, Doc, I've just sent you the video. I've sent it to Brinda to send it to you.
Okay.
Because we normally collect the videos from the parents to just see what exactly is worrying them about the sleep pattern.
Okay.
So, you will get that, and that happens with many children. And I find that these are also habits that we create. You know, the brain is something that wants the same thing, that wants the thing which we are not, because we used to rock my grandchildren to sleep till the world said stop, because he will want it for the rest of his days. And I think there are some things that we confuse the brain also, you know. So I'm doing my own studies after listening to you. So I think it's very important that we guide the parents, you know, so that they don't confuse themselves, or because their whole night the parents are staying awake, which is what is worrying me, because most of them have to go to work also. So yes, those are the concerns. Brinda, you've sent it? Yeah. So Doc, the video is with you. Okay.
I will have a look at it.
Yeah, have a look.
Yeah.
Yes.
Can I ask?
Yes,
No,
Brenda.
I don't. So this is a very, a question, sir. We would like to connect with you, like Rekha ma'am was saying. So is it okay if we connect with you to get a list of all the doctors or centers or whatever across the country, which we can share with our parents, because parents from different places would like to, like you said, see me, I'd be able to tell you. So if you can share that list, I'll connect with you again separately on that. So if it is okay with you, I'd like to collect that list from you, sir.
But Doc, we would like to know what are your charges if the parents connect with you privately, because you know our parents look to for support, and DSFI, when they connect, we also take a little bit of the onus. So it will be nice if we get clarity in a lot of things. So if you could send us a mail telling us that this is what you expect. So because see, we're not asking for anything, because even taking your time is not right. But thank you so much for today. And this was a major eye-opener. And I think we have one more question. Nidhi?
Yeah, Nidhi. Yeah,
Yeah,
considering
good
she's a doctor herself in our
evening.
cause,
Okay.
she'll keep her question precise. Nidhi, keep it
So,
precise
as
and
a
go ahead.
parent, first, thank you for this informative session. I have two very small questions. One is, do we have a similar study done for sleep apnea in Indian population? Because when I was surfing the net, I could not find one. The second is, as you had mentioned, we are very far behind in, in the application of the technology, because in West we have seen, like, we also work with sleep apnea, I mean, as dentist in our capacity, obviously, but we have formed a team in Delhi with, if you know, Dr. P.P. Bose. He is a renowned sleep specialist. So we have formed a team with him and ENT specialist here also in Delhi to help our parents. So in West, as you are aware, I know you're so forthcoming, and I really love the way you have done your research and studies. In West, we have this multidisciplinary approach where we ENT, the physician, the speech specialist, sleep specialist, and the dentist, they form a team. So can we look for such kind of team formation so that our parents are benefited in the maximum? I mean, we can do that maybe with DSFI in every state, because every member is important in this team. And if I just downloaded the latest, I may pass it on to you, from the British Columbia University, the role of dentist, the specialist dentist in sleep apnea, and what is the compliance of the appliance which is placed for sleep apnea. It's palatal expansion device, but it is just a general category. There are three type of palatal expansion devices which are given according to the age versus the compliance of the positive pressure, the device we have used. So if you wish, we can forward the study to you. I just downloaded it. So maybe, in years with doctors like you, we can look forward for some associations where the benefit goes to the community at the maximum. So
I mean, thank you for very detailed question. So, firstly, yes, there are no Indian studies to show that what is the sleep apnea effects on children with Down syndrome. There are, although we have reports of other genetic syndromes where Down syndrome has played a role. But with enthusiastic doctors like you, we can always form a cohort of our own. We can pull in data of our Down syndrome children's sleep studies, and then we can publish it if you are so interested. Two, I'm so glad that you're working with a team that focuses on a multidisciplinary approach with children with sleep issues. However, I somehow would like to question how well an adult sleep technician is trained in doing a pediatric sleep study, because it is an entirely different ball game as such. But if they are trained, then extremely good. Third of all, yes, multidisciplinary team is extremely important. Having a behavioral pediatrician, having an ENT, having a sleep technician, having a dentist, having a psychologist is something that we also try to do, and we have all of these in our team. When we do a sleep clinic, we do all of these together. We do an evaluation first, and then we refer to them based on what we find would be the next best step. And third of all, yes, in the future, we can do collaborations based on how well we're able to set up base going forward. And I am more than happy to help children with Down syndrome, because I believe like this is something that is not recognized at all. And then going forward, we should make a difference. Maybe someone like Dr. Rekha, who had to go to the UK to get a sleep study done and an evaluation. Maybe someone in the future is be like, I'm going to India to meet so and so doctor to get my child with Down syndrome treated. That should be our aim.
So, Doc,
Absolutely.
my question to you before we wind up is like, suppose you what for your study, how many subjects would you be looking at?
So we'll have to formulate a sample size, ma'am. Like we'll have to look at a subject. You really have to look at the research question in mind. See how many subjects. Even if in the beginning, if we pull out data and say like, no, we don't even have 40 children with Down syndrome and their follow up. See, but there are studies which show adenoidectomy and tonsillectomy and sleep study findings, myofunctional therapy and sleep study findings. We will require more of a follow up. We do a sleep study, then we follow up, we see how much residual OSA they have, what are the interventions that we do. Just by doing a data-wise study would not really be beneficial. We will probably start now, prospective study, we do it over the next 10 years, we follow these children and then see how many of them are the OSAs have settled down. We can break the study down into multiple compartments. It will be really beneficial.
So it will be after 4 years, up to?
I wouldn't say after 4 years as such. If your child at 2 years also is having sleep disordered breathing, you get a sleep study.
Oh.
Parents are not able to screen by the age of 4 years, then 4 years is a benchmark, you get it done by then.
Okay.
You can
And,
start-
and it can go up to any age.
Yeah. I mean, my expertise is up to 18 years, but beyond that, then we'll have to get an adult sleep technician, sleep specialist involved.
Okay. And you can, is your machines portable?
Yes, the machine that we have is portable because we have 2 centers and then we do it portable. And if you go to a sleep lab, then the prices are very different. And since ours are portable and we target a slightly different economic strata in mind, our prices are also very different.
And we have to come back and report only to you, or would you suggest somebody else who's working with you?
We work as a team as such. So if I'm not there, then my other colleague will manage the same, and all of the information is transmitted equally. So we can always work together and do
Okay,
it.
because I am very worried about the sleep studies in India. And honestly, this issue has come only for the last 10 years. And we never discussed sleep at all. We never knew. what was bothering our children, or why they were all the things that you've just now spoken about, was the reason was never sleep. It was everything else but sleep. They would say thyroid, they would say this. So this is a newer study, and like Nidhi said, this is not given to us at all as an important part of the development. So I think what we have to do now is to have you on board, and we're going to carry you as our package hereafter. You have no options. And because now you're already holding hands with DSFI, we want this because, see, pulmonologist and a sleep study go very closely. But some, pulmonologists cannot answer all my questions. So we would like you to be there. And yes, we will talk to you about your consultations. And if parents want to, we will give them your number. And yes, we can take half and half or pay for it because, they say the sleep study costs about 10,000.
So there are centers that do the sleep studies at 21,000 as well. And yeah, I mean, like I said in my talk, unfortunately, we do not cover this under insurance because we need more awareness. The government needs to start realizing that sleep study is extremely required. Maybe in the next decade, doctors like us can really put a foot down and be like, please cover this under insurance, and then they can claim. But yes, the pricing is something that is slightly on the higher side for an economical family. We do charge we charge slightly lesser. We charge between 7.5 to 10,000 based on we have different levels of sleep studies. And then based on the economical status, we decide, okay, fine, what are the values that we really want in this child? What are we really expecting? And then we do the sleep study, and then we will try to do our best.
So you can take it in one place, and we could call everyone to one place. Is that right?
So the sleep study equipment is 1:1. I can connect one sleep study equipment to only one child. So one night I can do it only for one child. So I cannot do mass sleep studies, and we don't have so many sleep study equipment to do a mass sleep study campaign also. So that would be a little difficult to manage.
But it can be done in their homes.
Again, home-based sleep studies is something that adults do. In pediatrics, we do not, because there are a lot of issues, especially when you have a Down syndrome child. They pull it off, they not cooperate. There are some nights where the child does not cooperate, they come back the next night. So that is why you would require an in-house monitoring in the hospital. Places have something called as sleep labs where it is you do the sleep study. But we have, since our price ranges are slightly lesser, we modify our wards to make sure that the parent and the child can sleep overnight and then leave early in the morning.
And it's an 8-hour or 12-hour? How many hours?
So the more we get, the better it is.
Okay.
And but the thing is, because all of these children would not really cooperate, even if we get around 5 to 6 hours of good data, should be really good for us.
Okay, so girls, we have a lot of sleeping to do.
Yes, Ma. We have really woken up to this fact, and thank you so much, Dr. Nagarjun. It was such a pleasure to listen to you, to understand you, and to go forward with you, because it's just not the X area. We want the concerns are matching, but also the spirit of contribution and to give away to the parents, and especially taking away from your own slide of the last of the season. We really want our doctors to sleep well, so we are going to disturb your sleep a lot for it, for the local consultation and also for the consultation in all the states. Thank you so much, Doctor, for being there.
One more thing, just one more question. Sorry,
yes, please.
Doctor. Sorry, I just need to know, sir. You also offer virtual consultation, right, sir?
Yeah.
So if the parents want to consult you virtually, and after this session, they might want to speak to you, or is it okay if we share your number or your email ID? Which one would it be?
Probably can share my email ID, because what I mentioned was my personal number. Then I would help you get in touch with my hospital admin, and then we can streamline it, because sometimes I would not take up personal calls and I don't want the parent that left out. And finally, thank you so much for having me. I mean, I know you support a very novel cause, and the job that you're doing is way beyond recognition. And apologies for all the parents that I didn't speak in Hindi. I can speak in Hindi, but then it is not the most fluent.
उसकी फिक्र नहीं करिए, आप आते रहिए हिंदी हम यहाँ हुए हैं।
I will slowly learn with you people.
No,
Yes.
no, no.
Yes.
Doc will teach you Hindi. You do
Will
us
do.
studies.
Yes.
I
Yes.
can speak Hindi, but then you probably
Which is totally fine, sir. There are some questions left in chat box, and we'll be troubling you with for seeking your guidance for that.
I've
Brinda will
already
forward it
shared
to you.
those with the
Yeah.
doc. Okay, I've
She
already
Yeah.
shared
shared
them
it,
with you.
so I think Doc can
Thank
answer
you.
it on thing. We can pass it on and put it
I've
on.
Yes.
mailed it, I've
Yes.
messaged it to you, sir. So whenever you have time, if you can
Time you
answer those
can.
questions, we'll
Yeah.
share it to the parents.
Yeah.
Thank you
Thank
so
you
much.
so much.
God
God
bless
bless
you.
Thank you,
God
you.
sir.
bless you,
Thank you
son.
for being
It
there.
was
Yeah.
amazing. We need more
Amazing.
young,
We
more
really need an
innovative,
applause for
and
you.
amazing doctors like you. Thank you so
Absolutely.
much.
Thank you so much.
Thank you, sir.
रेखा, शिक्षा, वृंदा जी, सेशन को यहाँ तक पहुँचाने के लिए आपका बहुत बहुत शुक्रिया। लगातार
Thank
बने
Thank you so much, everyone.
Yeah.
Thank you.
Thank
Thank
you.
you.
Bye,
Thank you,
everyone. See you
Parul.
all
Thank you,
next week.
Brinda. Thank you so much,
Thank you,
everyone.
Thanks,
guys.
Sammy,
See
and
you.
thanks,
Bye.
Parul. Bye, ma'am.
Bye.
See you.
Bye.
I'm ending.